I want to welcome everyone to tonight's Baltimore County uh, Fire and EMS Academy's lecture series. Tonight's speaker is Dr. Benjamin Lawner from Baltimore City Fire Department. He is the medical director for Baltimore City. He started his career, like many of us, watching emergency on television with Gage and DeSoto. I know it well. And became an EMT, participated in the fire department. I'm going to assume he got tired of being told what to do and went to med school and did his residency at University of Maryland in emergency medicine and a fellowship in emergency medical services, after which he got appointed as the medical director for fire department for Baltimore City. And he's a really cool guy. I've been on several trainings with him and it's lots of fun. So without further ado, we're going to be talking about arresting the trauma arrest. Stay, play, load, and go. Dr. Lawner.
Well, thank you so much. And apologies to those of you that get to see me again, but I see some of the familiar faces looking at you, Doug Sword. So yeah, it's funny. Dr. Siegel had mentioned, thank you for the invite, first of all. It is always an honor and privilege to teach. I think that's one of the easiest and most inspiring things to do. It's funny, as an EMT, I got tired of being told what to do, so then I became a paramedic, and then I got told what to do by firefighters. And then it didn't work when I became a firefighter paramedic because I was stuck in an ambulance. This sounds like a continuing theme. So, and now as a medical director, I'm told what to do by all of our hospital administrators and everything. So for those of you looking for autonomy, it's still cool to be a paramedic. But in any case, this is one of my favorite topics. We see this, unfortunately, in the city, where I know the most dangerous thing to do, as I always say, is mind your own business. We have a lot of penetrating trauma and gunshot wounds and traumatic arrest. So this is kind of a pulled together presentation about how do we kind of change the paradigm, because in the time that I first started talking about this, there have been a couple of position statements. So we're to take through that and or walk through those things. And let me know if you have any questions. Doug was my senior resident, so he trained me. So I blame him for any inaccurate information in the talk. His email will be provided in the chat in case you have any complaints. But in all seriousness, I know the chat will be monitored. So please go ahead and ask any questions. There will be lots of time for dialogue because, you know, as we know, nothing is simple, and these topics get pretty complicated. I was still trying to come up with a topic for this particular show, which was elusive. So finally I said, give him the finger. We'll talk about that with finger thoracostomy. So in any case, let's do something familiar for our Baltimore City inclined people. You arrive on the scene of a multiple GSW patient. And the patient has gasping respirations. You've got a blood pressure that's unobtainable and a heart rate of 130. The patient's diaphoretic, and you're located maybe 10 minutes away from the Intergalactic Shock Trauma Primary Adult Referral Center, which would be here where I'm sitting. And then, of course, we're reviewing Dr. Siegel's directive and listening to Jeff Nussbaum talk. The patient goes into traumatic arrest because that takes time to sort through. And the question is really, what do you do when you have this witness traumatic arrest? Witness traumatic arrests are some of the most dangerous things. And I could tell you what we do in Baltimore City. We do not stop. What we do for trauma arrest is we load them on a backboard, maybe. We put them on a Lucas device, and then we transport them to the hospital. And there are a lot of interesting discussions surrounding how we abscond with these trauma patients. And is it the right thing to do? You know, because I don't know about you, but when you say around the corner from a hospital or trauma center, it still takes time. Even if you're around the corner from shock trauma, and a lot of my paramedics like to say, you know, currently at this time, around at this time, currently at this time, you know, 5-minute ETA, but it takes minutes to actually unload the stretcher, to go into the door. Then you got to go into the elevator. And we actually time this with one of our crews. And even if you're 2 seconds away from the trauma center, it can take about 5 minutes or 2 to 5 minutes to actually get up to the trauma bay. And Sinai, it takes a while too with all of your construction as well, Dr. Siegel. So, you know, but it's a lot better than it was before, which is good. But it does take time. And my point is, we have to seriously consider what we're doing over here. So what is wrong with the modern EMS treatment of traumatic arrest? So a couple disclaimers. I don't have any disclosures, and this is a discussion about theory, not about protocol. So hopefully we'll have some really good discussions about how we kind of apply the medicine and I would love a work in progress. I would love to see the questions and the dialogue. So here, I think, are some of the things that are wrong with traumatic arrest. So we are lucky in Baltimore City to have a bunch of firefighters who can apply the Lucas device. Turns out the Lucas device may not be helping you. We also will stab people in the chest, sometimes reflexively. And I say all the time, this was one of the best things for me as a resident. So Dr. Siegel earlier was telling a story of where he got to open somebody's chest in the trauma bay. And because at the time, when I was training as a resident, EMS did lots of needle decompression, and that meant I got to put chest tubes in a ton of people. Whether it actually helped people, I don't know. And then sometimes we give them in a little bit of fluid, and that can be a problem. So here's what we're going to do tonight. We'll talk about indications for airway management. We'll talk about some position statements and really talk about best practices for traumatic arrest. It turns out in preparing for this, there was a recent policy statement. And this policy statement was from the National Association of EMS Physicians. Look at the poor broken dude in the middle. That's the American College of Surgeons Committee on Trauma and ACEP. And basically, we would love to hear from anesthesiologists too. But this was a combined position statement that said, what do we do for trauma arrest? And basically it said, we need to identify who the survivors are, because not all of the patients survive. If I were to ask you how many patients survive traumatic arrest, if you were to ask this question early, maybe even 20, 30 years ago, it was very low. We've made some improvements, but the first study on traumatic arrest was published by one of the first landmark studies was published by Dr. Ken Maddox. And the survival at that time, if you were out of hospital and you had traumatic arrest, the survival was like less than 1%. So we've come a long way. And these position statements talk about identifying reversible causes. And I hope it's not lost on this group. When you were talking about traumatic arrest, it's always about get off the scene. You got to be gone in 10 minutes and I got to worry about QA. Well, it turns out that leaving without doing something may be negatively impacting our patient's health. So we'll talk about that. If you look at that position statement, the paradigm of trauma arrest, notice before we actually get off the scene, we're talking about a couple things. First, it's the life-saving intervention. So you always got to prioritize the stuff that you know, bleeding control. And I'm going to try to make this appealing to obviously the EMS nerds out there, the people that also just want to get off the scene. I think we all can agree that bleeding control, hemorrhage control, fixing the reversible causes is important. Really identify who's going to survive these out-of-hospital traumatic arrests. We'll talk about who those patients are. And then the other issue is de-emphasizing chest compression. So there's a little bit of research out there that talks about, should we be really compressing on these patients' chests? So if you have a traumatic arrest, I'm talking about a blunt trauma, penetrating trauma, what is the value of chest compression? And if you search all the literature, just don't take my word for it, unless you're Doug Sword, who probably has resurrected somebody with his healing hand, it's really difficult to find literature that supports CPR in traumatic arrest. Very difficult. We do it as a bridge. We put people on Lucas devices, but it turns out the science is kind of messed up. So I want to call your attention to a little recent study, and this is not because this is a great study. This was a study that was focused on a couple of poor pigs that I guess they didn't meet the cut for getting bacon, but they looked at these pigs and they induced hemorrhagic shock. And basically, some of the pigs got CPR, and some of the pigs did not get CPR. So these pigs had like either sham compression or they had really good compression with an automated compression device, and they auto-transfused them, gave them the blood back, and looked at which pigs survived and what the parameters were. So this model tried to rectify the issue of traumatic arrest. So that was the issue. And if you look over here, this is the some of the results. So when you looked at the physiology, this was like a sensor basically placed inside the intracranial area. So the brain sensor, it looked at CO2 in the shoulder, on the leg, and the pigs that actually got CPR had worse parameters, and they also had worse mean ulterior pressures. And why is that? Why do you think that is? Well, that's because if you are pumping on a chest that has no blood, you're basically, remember the coronary arteries fill in diastole, which is when the heart relaxes. And so if you're pumping on a chest that has no blood, we're actually decreasing the diastolic pressure. And that was really interesting. So the conclusion of this small study, and again, I'm not suggesting this is the basis for all future research, but it's very consistent with what we've learned about outcomes, is that the patients, or the pigs, in this case, that got CPR, had a lower diastolic pressure, lower tissue oxygenation, and a lower mean arterial pressure. And so that says, it's not that CPR is bad, it's the fact that without filling the tank, it may not be helpful. And I contrast this with what we do now, because I'm sure all of us here that are clinically active have taken a patient, provided CPR, right, and have not corrected the underlying issue because trauma is a surgical disease and rush to the hospital. But it turns out that this physiologically may cause some problems. So Ben Launer is not saying, how do you do CPR in a pig? So Kristen is a researcher who's thinking about this, which is great. So this was an automated chest band device, and the pig was in lateral recumbency. But that's not the point. The point is we're extrapolating this research. So that's pretty funny. So it was a simulated model. But if you contrast this and you extrapolate the research to a lot of the people that get mechanical CPR, it has not shown any statistical benefit. And I think that's because you're not filling the heart. So again, it's not that CPR is bad. It's that we really have to figure out how to make CPR better. Now, for those of you that are lucky enough to be in a jurisdiction that has blood, that may be a part of the solution. The other solutions that we'll talk about is how do you reverse or treat those reversible causes. So again, follow your protocols, follow what your medical directors say. But I think if we're serious about reevaluating traumatic CPR and traumatic arrest, we really have to re-envision what we're doing, because CPR in the setting of a trauma arrest is not ACLS, right? These patients don't benefit from epinephrine. They don't benefit from the treatment of PEA or pacing. They need blood. They need filling of the heart in order to perfuse the heart and the vital organs. So when we say slap them on the Lucas and go, we may not be treating them to the most optimum physiology. So one of the things that we have said is we have tried to reconsider this or reconvene this. So instead of calling it, let's say, traumatic cardiac arrest, they're looking at it like pulseless hypovolemia. I mean, if you take an ultrasound picture of a heart, so if you take an ultrasound picture of a heart like this, that is, let's say, not filled, you basically have hyperdynamic contraction, meaning the heart is pounding and pounding and pounding, but it is very underfilled. So the heart is moving, right? If you were to take an ultrasound to somebody that has a witnessed traumatic arrest, in all likelihood, the heart's going to be underfilled moving. It's not true cardiac arrest. So maybe thinking about traumatic cardiac arrest with pulseless hypovolemia, meaning that they're really sick and you have a arresting of circulation because they're underfilled, maybe that will help us to prioritize intervention. So it's kind of an interesting consideration. And by the way, the Europeans have been doing this since 2021, and we'll talk about this a little bit later, but the European Resuscitation Council since 2021 has said it is not ACLS. And if you look, we'll blow that algorithm up at the end of the lecture, but it's controlling of hemorrhage, securing the airway, decompressing the chest. Obviously, if you have this, you'll be giving blood, binding the pelvis, and nowhere does it say there, let's go ahead and apply mechanical compression. Because it turns out if you just do CPR in an empty chest, these are patients that are not likely to survive. So it's a really interesting kind of reevaluation of what we're talking about. So a lot to digest. So far, what we're going to say, we're going to talk about traumatic arrest, CPR. Hopefully, I've made the argument that CPR may not be the best thing. And we don't have a protocol in Maryland that says don't do CPR. I am simply suggesting that if you're following your protocols, you also have to simultaneously think about reversible causes. And fortunately, in many areas, we're lucky to have more than one rescuer. So when we talk about the hierarchy of stuff we need to do for patients, maybe we need to do that. Now, Dr. Sagal was just telling this story earlier. Look at how relevant this is. We couldn't have rehearsed it better. This is a thoracotomy. And for those of you, especially speaking to Dr. Doug Sword, he knows the indication for a thoracotomy, meaning how do you open the chest? Why do we open the chest? The presence of the chest, especially as a trauma center. But this is what happens, right? How many of you have been to a trauma center? You have a patient in arrest, and if they're a candidate, the first thing they do is they open the chest. They open the chest because look at all the things that it fixes, right? So if you open the chest and the heart is surrounded by fluid and the heart has tamponade and can't squeeze, you can fix that. If you open the chest, you can fix a pneumothorax. If you open the chest, you can fix a hemothorax. And then you can also do something very dramatic, which is clamping the aorta. So this is a very interesting procedure because it's actually done. The question is, well, can we do this pre-hospital? Now, to do this pre-hospital, you have to have a couple of things, right? You have to have, more than a paramedic with a scalpel. You need a lot of training, a way to definitively manage the area, equipment to clamp the aorta, and ideally blood. And I love to talk about this. And it turns out London's been doing this since 1994. 1994, they did the first roadside finger thoracoscopy in London, which is always so nice to see. They're like, excuse me, not a problem. Let's wait a minute while we go ahead and open this chap's chest on the side of the road. And they do that because it fixes all the things. That was my best London accent. But they will actually literally land a helicopter on the side of the road. And if it is a witnessed arrest or an arrest that has occurred within 5 minutes of arrival, they will do this specifically to identify the survivors. So rather than doing compressions, putting them in a helicopter, they stay, they play, they do their procedure, and then they go if the patient survives. And it turns out, again, in preparing for this particular talk, they just published this in 2025. So they published a case series of what they're doing on the outskirts. Now, you may be thinking, well, what does this have to do in Maryland? We don't even have a protocol for this. But I know Dr. Siegel has a scalpel. I know Dr. Sword has a scalpel. We have a GO team. And I think the lesson of this is not that we should be doing thoracotomies, but EMS systems can do something more. And the lesson of the thoracotomy is not that we should be opening everybody's chest. It's the fact that we're addressing the reversible causes. So in London, they looked at all their thoracotomies from January 1999 to December 2019. They have a physician paramedic team. That's their London ambulance service team. And they have cool cars. Sometimes they land in a helicopter. They don't fly at night. They have their paramedics assigned to the aircraft with a master's degree, but they essentially will perform the resuscitative thoracostomy if the arrest is done within, if the arrest has occurred within 10 minutes. And here's their data, which is kind of crazy. It was a 21-year period of this. Can you imagine 45,000 patients, and they had about 601 of them. And look at the causes. So 17%, the traumatic cardiac arrest was due to fluid around the heart. The vast majority was due to exsanguination. Patients just bled out. And the vast majority, or another cohort was exsanguination and tamponade. So they had both. And really interestingly, 5% of them survived to discharge. Now, why is this even important? Because we're talking about such a small number. I just think it's highly ironic that we will right now, right, in Maryland and other places, we will compress somebody's chest, send them to the hospital, then they get thoracotomized. And just for perspective, the number of patients that survive an unwitnessed traumatic arrest out of hospital that present in asystole or PEA, it is as close to zero as you can get. So what we're talking about is how can we do better for patients that experienced a witness arrest instead of, option one is current standard of care where, again, put them on the Lucas and haul ass to a trauma center. Option two is let's rethink what we're doing. Can we get inside the chest, secure the airway, control the bleeding, replace the blood? And then in extreme cases, obviously, if you can't fix it, I think we should consider some finger thoracostomy or resuscitative thoracostomy. So it's kind of interesting. And you see the statistics there. 23 people had a favorable neurologic outcome. Now, of course, to put this in perspective, this is over a long time, but it's a better outcome than current protocols. So really interesting. So they proved basically it's a feasible intervention. And again, all of what we know is nobody survives. If somebody exsanguinated, nobody who received this procedure survived if greater than 5 minutes expired between the time of exsanguination or the time of arrest and exsanguination. So it's kind of interesting. So let's talk about how we modify our resuscitation interventions. We all know this is the trauma triad of death. Some people love to throw in calcium because that can be another problem that patients in traumatic arrest have. But fundamentally, it is a problem with blood clotting. They get very hypothermic and they get very acidotic. So if you don't perfuse your organs and you're just hemorrhaging blood, the problem is that causes you to bleed even more. And you get very acidotic, and that's not good. Your heart actually stops. And unfortunately, we kind of facilitate this in the field, right? You give people ringers, and ringers is not very physiologic. It's kind of acidotic. We do a lot of hemodilution. And then we also make people naked in the field, right? And so if you're not using warm fluids or if you're not using warm blood, we kind of make this triad worse. So what I would say is in the setting of trauma, well, how do we optimize our current protocols, right? So yes, one option is we can deploy physicians everywhere, which is not going to happen, and thoracotomize everybody, but we can also be very thoughtful about our resuscitation procedures. So the next part of the talk is going to basically focus on how do we administer IV fluids in the field. Yes, you administer it through a vein or through IO, but there's a couple of caveats here, and we've known this for a long time. So number one, large volume IV fluids quite bad, right? We do not want to, yes, thank you, Doug Sword. I just saw the indication. So we, unfortunately, the current protocol is 2 large bore IVs, right? And one study found that if you have a paramedic and you give them 2 large bore IVs, in one trauma system, more IV fluids were administered. So we want to be careful about dumping fluids. Now, if you have no perfusion and all you have is IV fluid, you want to titrate the IV fluid to perfusion. That means you're giving boluses of, let's say, 250 or 500 until you can feel a pulse or until you have signs and symptoms of perfusion. So just like the more you advance in your EMS career, from EMT to paramedic to nurse to doctor, and then of course to medical director, anesthesiologist, the more you realize that things are not black and white. So the take-home point for IV fluids is you titrate to perfusion, and I would say that's pretty concurrent with what we have in our Maryland medical protocols, right? We do not flood people with fluids. We have a maximum, and it's not that IV fluids are bad. If you don't have blood, you titrate to perfusion. And some of the bad outcomes happen with as little as 500 cc's. So unless you have signs and symptoms of poor perfusion, I am very cautious about giving IV fluids. So young patients can tolerate tachycardia pretty well, and they can tolerate lower blood pressures pretty well. But really, for me, it's the prolonged capillary refill, it's the altered level of consciousness, and then really profound hypotension, which is bad. So we've talked a little bit about, yes, compressions are part of our protocol currently, but may not be that physiologic. We've talked about how to kind of reverse those things. Let's talk a little bit about needle thoracostomy, which is my favorite topic. Every year, I have CT scans sent to me from the trauma center of providers that have what we call therapeutic misadventures, meaning we deploy the needles all the time, right? We deploy needle decompression, we decompress chest, and the problem is it's not really based on evidence. So yes, the protocol is you do it if you suspect a tension pneumo, but the problem is sometimes our diagnostics aren't perfect. So yes, it is a potentially reversible cause, but number one, depending upon how large our patients are, the needles may not enter the thorax. Number two, how do you decide whether somebody has a pneumothorax? So in several studies, and these have been done in major trauma centers, no matter how good you are with the stethoscope, and by the way, I don't know about you, Dr. Sword, I just use my stethoscope for a show. It is essentially to fill the time that it takes to get the patient to the CT scanner. I am convinced that stethoscopes are great, but they are fallible, right? They don't give you all the information. And in this particular study, not only did people misidentify the intercostal space, but sometimes the success rate was low and we didn't even get the diagnosis. Some of the time, the pneumothorax wasn't even there. And the reality is we don't have a CT scanner, right? So you're really kind of guessing. And not only are you guessing, but we're misidentifying landmarks. And I can just tell you, we'll show you a couple of pictures of where these needles go. But if the procedure is flawed because it's not perfect, if the diagnosis is imperfect, and if the needle doesn't enter the thorax, I would argue we have to really think about who we have needles in, because sometimes the patients can also suffer. And this is one of my favorite slides to show. So on the right, on the left side of your screen, this is what's called the liver biopsy. So you can see the needle, the thoracostomy needle in the liver, and the white around there, so there's the white that goes through the rib cage. You can see how low that is, and there's a little bit of white, which is hemorrhage. The middle picture is when the needle, so we all say, well, let's do the lateral thoracic space, so the fifth ICS. This is where it narrowly missed the spleen and did not even get into the chest. This one is where the needle was actually still retained inside the actual catheter, but it doesn't stop there. Here we have another needle on the left side of the screen. The catheter didn't go into the rib, same thing in the middle. And this is just showing that despite the needle's best effort, it didn't even get to the lung. And then when it gets into the lung, here's another one from a study in 2023 where the needle actually was large enough, went through the subcutaneous fat and the musculature, and then there was no pneumothorax. But guess what? Now you get a cool procedure because now the needle caused bleeding and an effusion. So this is what's called iatrogenic lung injury, which is essentially stabbing somebody in the chest with a needle. So I think this procedure, we have to be cautious about it. I've seen all sorts of attempts at identifying landmarks, but the bottom line is, please be sure you have an indication. And the indication is not shortness of breath, as we all know. It is suspicion of tension physiology. So you have a patient with tracheal deviation or absent lung sounds or profound hypotension, tachycardia, and they're in physiologic extremis, that's when we should deploy these things, because unfortunately it is not without harm. And I don't know if you had any really good, so this is a great point. So there's a great question in the chat about, will the protocol ever be updated? And I think it is. The protocol has done a long way. And notice I'm saying there are still things that we can take home from that as we're updating the protocol. I think finger thoracostomy did not make it into Maryland medical protocols, but our critical care crews, our Maryland ExpressCare, Johns Hopkins, MedStar, it's made it into some of the critical care transport services. So that's good. And I think the protocol also doesn't prevent you from being careful about the needle decompression. The protocol also incentivizes pelvic binding and hemorrhage control. So the answer to your question, Molly, is a qualified yes, but we've got a long way to go, because remember, protocols define the floor, and I think it's really difficult. We'll talk about maybe how to move the protocol needle. See, maybe that's a bad choice. We don't want to move the needle so much, but how to move the protocols forward. So bottom line here, reserve chest decompression for people with tension pneumo. Now, I think, as I joked about earlier, giving people the finger may be a way to actually do this. It's a simple technique. There are a couple of studies that are published that say you can actually do this. And for those of you that are BLS providers, or you're living in the shadow of some paramedic, the finger thoracostomy is not a technically difficult procedure. It's essentially what it says: the insertion of a finger into the pleural space. The advantages of the finger thoracostomy is you basically evacuate air and you evacuate blood at the same time. So it opens your treatment. Now, remember when we talked earlier about why do people die from trauma arrest? They die from tamponade, and sometimes tamponade is the filling of blood in the chest where it pushes the heart away, or you have a tension pneumo. And I don't know how many of you have done a needle thoracostomy, but you'll get blood out of it, but it is not going to empty a crap ton of blood. That's my specific, research-based metric. It's not going to empty a chest of a hemothorax. So the advantages are you remove blood and air. The disadvantages are, again, diagnostics, and you need trained people to do it. And again, in the city of Baltimore, at least, we're very short on some ALS providers, but it does remain an option. There is one study that talked about how it is feasible. There's a new journal, by the way, if any of you are interested in publishing, it's called the International Journal of Paramedicine. And basically this showed that it was also a feasible procedure associated with a high mortality rate. And basically patients were able to decompress the thorax, or the patients that had the finger thoracostomy had their thorax decompressed a lot better than those that had the needle. So unfortunately, there's not a lot of literature. It just suggests that it is possible. They did this study also in Australia, and just to expand upon that a little bit, their indication was if you had an unconscious patient or a patient in traumatic arrest, they had 76 cases, and in that particular study, they found 3 complications. That's like a 4.8% complication rate. I've had these conversations with, MIMS, and part of the concern is, what do you do next if you open somebody's chest? You're not going to give them blood, who knows? But I think the literature is out there that suggests that it is feasible. We can train EMS providers to do it. And I really struggle with this because, yes, it's a risky procedure, but so is needle decompression, right? We think it's less invasive, but number one, does the needle help? Is it actually fixing the underlying problem? So the debate continues. And, to Molly's question earlier, I think we've had some success in moving, again, this needle forward for the critical care transport team. So we'll see what happens. So let's talk a little bit about tools and trauma toolbox. There's probably a bunch of paramedic and EMT providers in the audience that have seen ultrasound. This is where you start. This is another thing where the protocol is approaching best evidence. There's a lot of discussion about ultrasound in the setting of trauma. And for full disclosure, the literature is not amazing. But as with anything else in ultrasound, you have to basically ask the basic questions with the device. So if I were to look at all the studies in ultrasound, it's very difficult to find a huge mortality benefit, right? You're not going to, the studies aren't going to show you that, oh my gosh, because I gave an ultrasound to this paramedic, somebody lived. But what it does do is it informs your diagnostic assessment, meaning if you have a patient in trauma arrest, this is something that can help survival. For example, let's say you have the case that we talked about, right? The patient loses pulses. If you put the ultrasound in somebody's chest and you see this, which is a heart that's not moving. Now, I know this is a still slide, but assuming the heart was not moving, if you have cardiac standstill on ultrasound due to trauma, nobody survives. We did a preliminary data review of over 30,000 patients. Yes, it's a sad state of Baltimore that we have this much penetrating and blunt trauma, but over several years, there were 35,000 patients. Of those that underwent, either pre-hospital, or I'm sorry, in-hospital thoracotomy or were in arrest, none of them survived if they had basically a negative ultrasound or if they were in arrest and asystole prior to arrival. So I think the evidence is pretty good that if you look overall at these patients that are in extremis, cardiac standstill on ultrasound, unwitnessed arrest with asystole, those patients don't do well at all. But why? How can ultrasound be helpful? So let's look at this one. This is where it can be helpful. So this over here, these are two pictures of the lungs. This is essentially somebody using a pre-hospital ultrasound, and the probes are like this, they're handheld, and you basically put the probe on the chest. This is just looking at an anterior picture of a lung. On the left side, I don't know if you can see this, but there's not a lot of movement. So on the left side, what you're seeing is essentially, you see the white line in the middle there? That's the pleural interface. So that's basically the line of the pleura and the lung below it. And if that is not moving, that is indicative of a pneumothorax or maybe a significant hemothorax. So if you see no lung sliding, which is what you see on the left, that's somebody that may benefit from a needle. So this is an example where as services mature, as you convince service leaders to buy different things, the ultrasound can really inform what you do for your patients. On the right side is basically your lung sliding. So you guys see that the movement, you see the white line, it looks like there's things marching across the screen. You even see these what's called comet tails, which are kind of streaking down. So behold the wonder of ultrasound. So if the question is somebody is in let's say in significant distress, they get stabbed in the chest, and you're wondering whether you should decompress them because they have a low blood pressure and a high heart rate, on the left side of the screen, decompress that person. On the right side of the screen, do not decompress that person. There's no pneumothorax. So really interesting. This is another better view of this. This basically on the left, you see, again, lung sliding, and it's been demonstrated that paramedics can do this. You just basically ask the question, even if you don't know what all these structures are, of course, hopefully that you would undergoing a trauma training program. On the left slide, you have lung sliding, and on the right side, you have no lung sliding. So again, on the left, no pneumothorax. On the right, possible pneumothorax. So I know that Talbot County, and I know Doug Sword, my partner in crime in Hartford. Doug, anything to add about ultrasound? I don't want to put you on the spot, sir, in case you're in the bathroom drinking beer or at the hyperbaric chamber, but anything you want to add about ultrasound? Because we have a couple of counties that are.
Yeah, just can you guys hear me? I think that ultrasound can be helpful because we've had a couple of cases where either there was no pneumothorax or the needle was placed, like your earlier case, into the liver. And so I think determining if there's lung sliding or not, and in the case of a pneumothorax, there would not be, and then actually rib space to make sure that the needle actually goes into the thoracic cavity and not into the abdomen is helpful, at least in the non-arrested case. I think you're sort of between a rock and a hard spot if they're in arrest, but if they're peri-arrest or just sick, I think it's very helpful, actually.
Well, there you go. You heard it. So end the lecture right there from the mouth of authority. So this is where, again, you have to have your indication. So, and thank you, Dr. Sword, for that as well. I really love the comments too. So one of the issues are, so by the way, I'm sorry, I saw the second part of Molly's question was, what about controlling the bleed and not doing CPR? So I think that's really difficult because if you look at the chat, the question is, what about the airway staying open and transport without CPR? I think that the question is more about the reflexive application of CPR and neglecting other things. I think you're really stuck, right? If you're going to transport somebody and do it safely, and if the decision is you're transporting, I don't think there's enough evidence to just don't do CPR. I don't think the CPR is the thing that's causing the badness. It's neglecting the reversible causes. So I'm simply stating that we should deprioritize it and move to a protocol in which you transport those patients with either ROSC or you're so close to a trauma center that you can literally get to the trauma bay within 5 minutes. So anyway, this is an example of a FAST, and I struggle with this one. So the FAST is essentially a focused abdominal sonography and trauma. It has a couple of abbreviations. This is where you basically put the probe on somebody's chest or on somebody's belly. Now, on the bottom of the screen is ribs. On the top of the screen is basically the anterior chest. The head is to the left, the feet are to the right. And what I'm trying to show you here is basically this cord liver that is floating in some blood. So this is what we call a positive FAST exam. This is fluid. And where I struggle with this is in EMS, and I don't even do this routinely with my crews. We were deploying this in Baltimore City. I really struggle with what you do with this information, because if you have a decent mechanism of injury, what are you going to do with a patient with significant abdominal pain, bruising in the chest, tachycardia? You're going to transport the patient to the hospital, right? You're going to transport them to a trauma center. The problem is, if you don't have this and you have blood, you could have blood, let's say, in the retroperitoneum, which is kind of like behind the kidney. Ultrasound won't detect that. So I really struggle with what to do with a FAST exam. There's some evidence to suggest that if an EMS service finds they find a positive FAST, maybe that decreases the time to OR. But I would just suggest that whether the FAST is positive or not, if you have lung sound criteria, mechanism of injury criteria, you're going to the trauma center, right? It's not like you would say, oh, let's not take these sick patients over there. So in any event, all right. Okay, give me 1 second, because that's my crew. I will be, pardon me for that. Okay, so that's the FAST. Any questions about the FAST exam? No questions about the FAST exam? All right. So there is the heart that's also hyperdynamic. The heart that is hyperdynamic basically is showing you that it should be filled. That's where basically the heart is contracting, and you have basically the blood. So the black is blood is what I should say for this. So when you see this, that is the blood. So let me see. So excuse me 1 second. That's actually my crew. I apologize. So sorry. 1 second. Doug, please feel free to talk about ultrasound.
Okay. I agree with Ben on the positive FAST. You should probably be going to trauma center for mechanism and vitals alone. As an aside, in the female that's pregnant with a positive FAST and abdominal pain, then ruptured ectopic pregnancy could be considered and could be an indication for whole blood administration as well, although that's not obviously a trauma case and not why we came to listen to Dr. Launer today. So in Harford County, we have had ultrasound for a couple years, but it's been slow to pick up, and we haven't found a positive FAST quite yet. We have found AAAs that were huge, like 9 centimeters, and some pericardial tamponade and a lot of lung ultrasound. But again, that's not a trauma case. So I agree with Launer. This is helpful, but not definitive, I guess would be the answer there. The pneumothorax part, I do think could be quite helpful, as I mentioned earlier, in terms of confirming pneumothorax and an appropriate needle placement. Does anyone have any questions on that? I see a couple of Harford County medics on the call here, so thank you guys. Poaching in on Baltimore County. We're going to be having a ultrasound review session actually tomorrow for some of our medics that are still working on being credentialed. Hopefully nobody has a positive FAST exam because they're going to be normal medics that we're scanning. Thanks, Sagal. Thanks, man. But yeah, let me know. I don't know what he has next on the slides. Lon and I have done a couple of thoracostomies in the city for penetrating trauma. I think it's all been GSW cases. And clearly more effective than a needle decompression. Looks like trauma airway management is up next. Not sure what the slides are going to be, but one of the things you could do, at least with ultrasound, is identify bilateral lung sliding after intubation to help you confirm that you have the tube in the trachea, as the lungs wouldn't be sliding if you were in the esophagus.
It's interesting. I think ultrasound will be coming to the field a lot faster than not. Literally, you can get a ultrasound probe and attach it to your iPhone at this point, if you don't mind spending a couple $1,000s. But people are doing that. But the cost is coming down. The the skill is, it's not as hard as people think, and the accuracy is, or the picture is exponentially improved now versus what it was 30 years ago.
Oh yeah, easily.
So
Back when Ben and I were in training, yeah, 30 years ago, we had
sorry.
big bulky machines, but they're small. I've had sort of slow uptake. It took us a while for the logistics to work out and get the equipment on the trucks. And again, people are it's not a primary thing. They got to do ABCs and such first. But we're having more and more experience with it, and it's pretty interesting.
Yeah, no, I've seen a few hands, and they're first it was the, well, you can find blood vessels for access. And all of a sudden you realize, oh, this little thing will see the heart, or I can see inside the chest, and it's the future, and it's a lot sooner than we think.
Yeah,
But
we're doing a lot of heart and lung ultrasound more than trauma ultrasound, to be honest. Identifying pulmonary edema and then doing it in cardiac arrest and finding like the pseudo PEA picture and trying to figure out what to do with that.
Agreed. Can you all hear me? My apologies.
Yeah, you're good.
Sorry
You're
about what an excellent lecture. The EMS knows no bounds. So it's funny. I apologize. That was another air crew. But sounds like some amazing, not thundering silence from the crowd. So I appreciate that. And we will certainly continue our journey. So I promise I will make it up to you. Just ordered one off Temu. That's great. We've even got a lot of people in the chat too. That's perfect. So let's continue to trauma airway management. And by the way, we'll have time for those of you that I promise we will make up with any questions that you have. I want to move on to just trauma airway management, because we talked about ultrasound may not be a mortality-based intervention, but it may inform all the stuff that you're talking here currently, right? So it can help you with the decision to go to an operating room faster. It can help you with the needle decompression. Airway management is one of those evidence-based interventions. And what's interesting is there have been a lot of studies. So for those of you that want to look at when people say EPIC, EPIC was a trial that focused on traumatic brain injury and basically affirmed what we already know in airway trauma, which is essentially that, number one, what's bad in the setting of airway management is if you have hypoxia, if you have hypotension and hypocarbia. And this trial, although it looked at brain injured patients, it showed that if you weren't able to maintain perfusion, and this was one of the first airway themed trials that actually showed a signal of harm with an objective blood pressure target. So this is what's interesting. So the question is, you're stealing my thunder about advanced airway or BLS airway with good compliance. The EPIC trial looked at all of that. So if it's ALS, it talks about an advanced airway, and BLS airway could certainly be managed non-invasively. So as we progress through this, the bottom line with the EPIC trial is that the mortality-based intervention is basically avoiding hypoxia. So if you have a trauma patient that is sonorous, and let's say you don't have RSI capacity, this is where you're kind of stuck. You'd use your, sonorous with trismus, your two nasal pharyngeal airways, and you try to ventilate to the best extent possible. So when you look at airway management and trauma, it's about effective ventilation and also avoiding the low oxygen saturation. In this case, they recommended better than 90% SpO2. I do not think there's enough evidence currently to suggest that patients need to be intubated. However, I think for patients that are traveling any degree of distance, it does make sense to be able to control the airway a little bit. And especially with traumatic brain injury, patients do worse when they have, that hypoxia. And if the brain swells, you can target the end-tidal CO2. So really, it's the first evidence for airway control, less evidence for whether you need to basically intubate or manage it non-invasively, but it is extremely important. It is extremely important. And I think you're safe to say that if you're a trained paramedic and a trained EMT, and it's within your protocol, advanced airways are probably preferable, but then that gets you into a lot of problems because, my gosh, Molly is with the amazing on-point question. IDL should become a BLS thing. It is actually in the National Registry. I know that's being hotly talked about. So I think you have some support with respect to medical directors. And it's for precisely this reason that I think we really, it's time the time has come to kind of consider eye-gels. I think I can't speak for MIMS, but the biggest issue in Maryland has been if you put an eye-gel in, I agree. If you put an eye-gel in, then you need to monitor it with end-tidal CO2, and end-tidal CO2 is not within the scope of a BLS provider. However, I think we can reword the protocol to where if you put an eye-gel or an LMA in, and you basically see a waveform and not monitor it, then you're good. So this is and I know this is near and dear to Dr. Siegel's heart as well, but airway management is of prime importance, not a great amount of evidence. I think where we really get into what's tricky is RSI. And RSI, people love RSI. If you look at my, paramedics, we do not have RSI in Baltimore, but our paramedics would love to have RSI because, you want to get the tube in the right hole and you want to precisely titrate it. But this is where it's a real challenge. And let's just say that more is not better. And the evidence out there does not tell you how to basically, what medicines to use, how to use it. And especially in patients that are sick, how do you avoid the complications? And let's just take this one step further. So totally agree. Couldn't have said it better myself. The goal is to oxygenate and ventilate. Now there are circumstances in which RSI is indicated. So let's talk about the patient with trismus, isolated head injury. You can't oxygenate and you need advanced airway. Here's the other problem. Remember I said earlier, the more you go down your training pathway, the more gray that things get. When you have patients that are hypotensive, when you have patients that are shocked, and again, if you have a high shock index, there's something very unpleasant that occurs called periintubation cardiovascular collapse. And periintubation cardiovascular collapse is basically one of those things where it's a complication that occurs in about 30 to 40% of patients who are in extremis. So we have to be very careful. And remember, when you go ahead and intubate these patients and you give them positive pressure, you transition from negative to positive pressure, even with a bag valve mask, you run the risk of this occurring. And the challenge is that positive pressure is not benign. So for those of you that are on the advanced end of the spectrum here that love all of the medicine and the drugs, realize that a risk of peri-intubation cardiovascular collapse is not at all insignificant. And it happens even in the hospital. So just be very careful with patients with a high shock index because there is no idealized protocol for this. And that's why RSI, it's not about getting the tube in the correct hole. It is about basically, and we'll talk about the pneumothorax with end-tidal, it is about doing the right thing and resuscitating your patients before you intubate. So just in terms of general airway, avoid your hypotension, resuscitate to the extent possible before you deploy an advanced airway, because these procedures are at high risk for a bad outcome. Checklists help. And in my opinion, this is just Ben Launer's opinion, so this is where you can blame me and not necessarily Doug Sword. But for jurisdictions that do RSI, I firmly believe that you have to have a protocol for cricothyroidotomy, vasopressors, blood, and really have a good understanding of ventilatory management, because once you do RSI, you have to own all the complications. It's not like you can push the paralytics and be like, well, the ventilator's not working. So it's just a very high risk event. And the interesting thing is medicine, even the doctors in the hospital have not figured out the best way. And as a matter of fact, we were at the Air Medical Transport Conference last November. We had a whole panel about this. There's going to be, look at your Air Medical Journal. There's going to be a big position statement coming out about this, which is essentially a great document that's exhaustive and says, I have no idea what to do. But it basically echoes some of the challenges with this. And interestingly enough, this was a recent study that was published in 2024 in a very high performing system, physician and paramedic staff system that had a huge scope of practice. And they basically found that even they looked at it from 2015 to 2020, ages 15 years and older, and they had 1,500 patients. They were doing this. They introduced checklists. They had a standardized regimen for induction. And they found that the patients at the highest risk for this were those that were older than 55, had multi-system injuries, had tachycardia pre-hospitally, and got any degree of intravenous crystalloid. So this just illustrates, again, the pitfalls of this particular procedure. So I would respectfully suggest that the question of reflexive pre-hospital RSI, meaning should everybody do it, that is a question that we currently do not have an answer for. I think for those of you that do it, you have to be under the care of some amazing medical directors, like some of them that are on this particular, training, where you have contingencies and you're fully resourced, because it is a very dangerous thing that needs to be resourced with all of the appropriate resuscitation. So what are the take homes? RSI may not be the solution. And this is really difficult. We could say maybe for next time, if I don't get interrupted and I don't piss enough people off and you invite me back, we can have a whole discussion about ideal pre-hospital RSI. It's very difficult. Turns out if patients are fine, if patients have a pre-hospital, that's right, I know. If they have a pre-hospital systolic blood pressure of greater than 140, that's protective. And interestingly, if one of the other things that was said in the study is that the paramedic was very worried about the patient, that was also predictive as well, meaning they wanted to avoid the sedative. So the patients that did not receive pre-hospital fentanyl, because some of them give that to like attenuate the airway reflexes, but if the paramedic or the doctor was like, oh crap, this patient's going to do well, and they admitted it, they did worse. And I think that's because those patients were really more in extremis anyway. I can tell you there's a system in Houston. My friend Chris Stevens, who some of you may be old enough to remember, Doug, not calling anybody out, but Chris Stevens was a trauma anesthesiology fellow. I rotated with him, and his system for comatose patients, GCS 4 and 3, that are in peritraumatic arrest, they don't give any sedatives at all. They just do paralytics. Now, I am not saying, and this is going to be recorded, so I'm not saying that we should not give sedatives. I'm just suggesting that this procedure is so dangerous and fraught with peril that there are a lot of approaches. And some of the approaches are, one, minimizing the sedatives. And interestingly, their preliminary data states that patients with a GCS of 3 don't have any recall, or GCS of 4. That's what their data show. Certainly, it's not big enough to make a decision about. But the issue is, would you rather have an increased risk of cardiac arrest or avoid the sedatives? Because as our anesthesiology friends and colleagues know, sedatives, there's no such thing as a hemodynamically neutral drug. One of our air medical director colleagues is a cardiac anesthesiologist, and he basically has literature where he puts a SWAN, which is an amazing catheter that monitors multiple hemodynamic parameters. He puts the SWAN in somebody's chest, and even with small doses of midazolam, small doses of fentanyl, small doses of ketamine, patients have hemodynamic reactions. So what's the answer to this? Stay tuned for next year's Baltimore City, Baltimore County lecture. We don't know, but I'm suggesting it's high risk. And I would go back to what Dr. Siegel said, which is when you start ventilating these patients, the goal is to do this in the pre-hospital setting in kind of the least invasive way possible that preserves ventilation. There's actually even another study, which is very, it breaks my heart to say this, but it was conducted in a level 1 trauma center, and it actually showed better outcomes when intubation was deferred until arrival in the operating room, meaning patients in the emergency department did worse if they were intubated in the setting of traumatic injury. Doug, doesn't that break your heart? I don't know. It just makes me crazy. Any discussion about this?
Heartbroken.
I know. Now, Chauncey King had asked about, can you pick up a pneumothorax with this? I would argue that pneumothoraces are not reliably detected with end tidal. So this is just my opinion, but remember, you can get a very low end tidal with poor gas exchange from poor perfusion. So it is very non-specific. You can use end tidal to support your diagnosis, but I would posit that end tidal is not specific for pneumothorax. And you never know. What if you have a massive PE and you have low end tidal, and then you think, oh, maybe it's pneumo. So what I use my end tidal CO2, just like with ultrasound, is I ask some very basic questions. Very basic, that's true, sir. Very basic questions, which is, number one, is the tube in the right place? Great question for end tidal CO2. Is it a low perfusion state? Great question for end tidal CO2. Are they acidotic? Great question for end tidal CO2. You can trend perfusion. I think that it's not good for airway pressure. So Dr. Siegel is very kind too. You can use airway pressure to pick up attention pneumo, certainly, and we'll talk about, there is another discussion to be had about what happens when patients are on a ventilator. So Aaron also says, and this is where you guys are asking some amazing questions. So Aaron had asked about, for intubated TBI patients, what do you prefer? All I would say is I would be very cautious personally with midazolam. I think midazolam is one of those drugs that therapeutic curve is all over the place. If I give a 70-year-old patient 5 of midazolam for seizures, they could be hypotensive or awake. You never know. And hypotension is a real worry. I would argue that in a time of stress, this is pre-hospital, the last thing you want to do when you decide to RSI a hemodynamically stressed patient is, oh, well, should I use midazolam, ketamine, fentanyl? Should I use Propiket? should I use etomidate? You really need a simple toolbox. And I would argue that in the pre-hospital setting, and this is based upon our experience with PHI, Air Medical, STAT, and a couple of other services, I would choose a single induction agent. And I think ketamine and rocuronium are probably fit the bill for most patients. That's not because I think it's the best, and it's not because I think it's the most evidence-based in all cases. It's that we need something simple that carries low hemodynamic risk, that is not likely to cause significant hypotension. So if you were asking me personally what I say for our crews, there's a big discussion to have had, and there's all sorts of reasons we use ketamine and rock, lots of other things to do that. Can you use succinylcholine? You certainly can. There's lots of pluses and minuses, but that is a very big discussion beyond the scope of this particular lecture, unless you want to stay for virtual viewers, which we can probably hammer that out quite a bit. Succinylcholine is certainly a good drug, but there's a lot of questions about increased intracranial pressure and side effects and what happens, how do you redose suck? So I try to make it simple. That's what we use here. Lots of discussion. For ventilator settings, for those of you that actually utilize, ventilators, I think this is the wave of the future. We talk about some lung protective ventilation, and basically that's something where you minimize your massive airway pressures so that you can deliver adequate ventilation without causing so much increased intrathoracic pressure. So if I, for example, start bagging the crap out of somebody, and I'm just taking it at its most basic level, right? So yes, non-invasive ventilation, and this is why it gets very complicated. Non-invasive ventilation, if you're doing it too fast, you increase intrathoracic pressure, and increasing intrathoracic pressure decreases venous returns. That can be bad. So the last part of this talk gets into really what do we do, right? So let's kind of synthesize everything. We've talked about airway. We've talked about how there's implications for BLS, ALS, and even advanced providers. Circulatory arrest is a real problem. And again, I think there's a couple of lessons to be learned. I want to give a shout out to Philly, which is our sister and brother city to the north. By the way, did you know that since 2011, now this is a policy from 2018, but from 2011, they were putting people in police cars and transporting them to the trauma center. They have been doing that reliably, and it still happens. They have research to show that those patients do just as well as patients being tended to by an ALS ambulance. Now, I'm sure there's uproar saying, well, what the heck? You just gave us a whole lecture on we should stay, play, and do all the treatment. This has a little caveat in it, which is rapid transport is indicated if the ambulance is not there. And in Baltimore City, we have that problem regularly. I mean, we have a paramedic shortage. We have 30 full-time units, plus or minus 4 surge units. There are times when people are shot and there's no ambulance to provide the rapid transport. And there is some evidence to suggest, to swallow yet another piece of my humble pie, that if you don't have resources there, what about rapid transport? So if the patient is pre-arrest, they have been doing this for penetrating trauma since 2011, and they've had good results. So really important, and they've studied it multiple times. But I would only propose that in the setting when there's no other transport apparatus there. So really interesting. And they've been doing that for a long time too. The first official policy I've seen, and thank you, Dr. Sagel, too. The first official policy I've seen is in 2011. So remember, I referenced the issue of European Resuscitation Council guidelines in 2021. This is, I think, the first major sort of system to say we really need to de-emphasize chest compressions. And I think it's important to reevaluate this because, as we said earlier, historical rates of survival are so low. In 2006, London HEMS again published their first series on traumatic arrest, and that was the series which actually said these patients survived. So their 10-year look into this, which was published in 2006, showed that 68 people actually survived traumatic arrest because of the stuff that we're talking about. And that's incredible. And if you look at your CARES registry, which is your cardiac arrest registry to enhance survival, 7.5% is pretty darn good, meaning that it is not zero. So again, we leverage all these resources, including rapid transport and EMS officers, Lucas devices. Maybe we should think about how we can optimize and further kind of push this number. So in their study, 7.5% was obtainable, which was very good. So here's the trauma arrest study that basically talks about it a little bit more. Way back in 2006, they were not giving blood, but that actually showed the better outcomes, even with a very targeted approach to traumatic arrest. What are some poor prognostic factors, by the way? As we know for circulatory arrest, these are a couple things. Number one, if the arrest is unwitnessed, remember we said earlier, those patients don't do very well at all. If the patient is asystolic on their initial rhythm, very negative predictive value. And again, if there's no motion at all on cardiac ultrasound, that is another negative predictive value. So maybe even if the protocols aren't so advanced, we can talk about how to actually identify the survivors. Because if you go back again to what we talked about earlier, which is how do we identify those survivors, we can actually risk stratify them by a couple of things. So this doesn't require a lot of advanced sort of technology, right? This is stuff you have available kind of at the bedside to you, which is the asystole, a cardiac monitor, obviously unwitnessed arrest, no cardiac motion. So I think the modern management of these peri-arrest kind of traumatic arrest patients has really changed. And, jurisdictions that have blood, it's very exciting. So jurisdictions that have blood, I think, have the potential to actually increase outcomes even more. And actually, there are many jurisdictions that are either working towards blood or that are on this call right now that actually have it. So we can certainly identify these evidence-based therapies and leverage these therapies to actually increase better survival, right? And that's what we've been talking about. So let's go through this just to kind of recap before we kind of look at our case. So you have the patient that is in peri-arrest. You have the patient that is traumatically injured and they're in extremis. Most importantly, if it's a medical cause, so they've been in a car accident due to a medical cause, they're having a STEMI, they have a dysrhythmia, that is a medically treated arrest. For those patients that are bleeding, before we say, hey, let's get out of here in like 10 minutes, let's get off the scene, let's talk about how we actually can treat those patients. Number one is the control of external hemorrhage, which I think we all have, right? We've got combat gauze. There's actually, Baltimore City is trialing something called the seal spray, which is aerosolized kind of chitin. So it comes out at like 80 PSI and you squirt it, don't squirt it in a wound or squirt it on a very young patient because it comes out at like 80 PSI. So we're actually trialing this, and it's been authorized by Maryland Medical Protocols. They consider it essentially a hemostatic agent, where you spray this aerosolized chitin, it forms a gel on the wound, and that can perhaps stave off external hemorrhages. So we have that. We have combat gauze. We have tourniquets. There's some really interesting studies about junctional tourniquets, and junctional tourniquets are basically inflatable gas bladders that can be used to position on the junction. So the axilla, the groin, sometimes they actually can go around the abdomen and compress the aorta. So I think there are a lot of advances that are happening with respect to how we actually get around the issue of stopping bleeding. There's also the securing of the airway, and notice in the European Resuscitation Council, it does not specify you need to intubate patients. It says oxygenate and ventilate. It says essentially secure the airway and maintain oxygenation. And we know from our data with the EPIC trial and all others, we should probably aim for an oxygen saturation above 80 or above 90% if that's possible. The other thing is there are some interesting things to look at. Number one is relieving the tamponade. So you saw on the initial studies that if there's fluid around a heart that prevents it from contracting, that is something where you can do a pericardiocentesis, or if you're in London, they just do the thoracotomy, so no problem. There's interesting stuff with Reboa. Now, Reboa is kind of cool. Reboa is basically this fancy catheter where it's called resuscitative endovascular balloon occlusion of the aorta, Reboa. And basically it was done first, this was back when I'm not old enough to remember this, but this was done back in the Korean War initially, where they had a balloon that they thread up through the femoral artery. It would go up into the aorta and essentially occlude all the downstream flow. Now, the challenge is this has been studied extensively in London and other places. The GO team can certainly onboard this therapy, but there are unfortunately not a lot of good studies that show a decrease in mortality. But Reboa, in a system that is so encouraged, can certainly try that. Now, I don't know what your experiences are with this. So that's really interesting. I don't know what the experiences are in your center. I don't know if, Dr. Sagal, have you seen them deploy the Reboa catheter at all in Sinai? Sorry to put you on the spot. I'm just curious because they love that here too.
It's just something people are just now starting to talk about. It's new. It's
yeah.
I don't know of any jurisdiction in Maryland that's using it. I don't know of any federal agency. I also in the medical director of the United States Park Police, and this is just very new, and there's
Yeah.
just a few preliminary discussions. We talked about it in the ER with the trauma meetings about the surgical teams on arrival deploying something such as this, but it's all still in the very preliminary stages.
I think that's a really good discussion. I mean, EMS, we love to also adopt the new things. And I think our system, right, I think we've come a long way in basically raising the floor. And Reboa is kind of cool because the thought is, you don't need to be in a trauma surgical environment, right? I mean, emergency physicians, EMS physicians, anesthesiologists are placing lines all the time. I'm sure in the OR, you've placed more than your fair share of IV lines. And Reboa, basically, you put a catheter in the large artery in the groin and you thread it up from there. The question is, there's a thought of it can be done pre-hospitally, and there are only a couple of systems overseas that are doing this with any degree of regularity. There's a system in France, London, of course, and roll my eyes again. There are a couple of other services that do that, but you have to deploy it in a system because number one, if you occlude the flow, right, distal or past your aorta, there's the issue of downstream ischemia and starvation of blood. So there's a lot of thought about bringing the balloon up and down called partial Reboa. But you can imagine how hard it would be to get somebody, once you occlude the aorta, you only have about 60 to 90 minutes to get them to definitive surgical control. Plus, it's a technically difficult procedure. There are some military units that have experimented with this in the forwardly deployed issues, so American Special Forces units. But I agree with you, Dr. Sagel, it's not here for prime time. I think the bottom line is survival from traumatic cardiac arrest isn't about the next cool toy, right? It's about blood and reversal of causes. And I think if you can't identify a reversible cause, or you can't treat it, we have to have that serious discussion about should the patient be transported. And so some of these advances in pre-hospital trauma protocols are really about logistics, right? They're really about what do we do for these patients? What's the best form of therapy if they're asystolic? Like, do we still transport them to the operating room or transport them to a trauma center if we know that there's no tamponade, which by the way can be seen on ultrasound, if we've treated the pneumothorax, and if they're in arrest. So this is where if you look at this evidence-based guideline, it talks about consideration of termination of resuscitation. So that's another, by the way, another target for protocol modification, where maybe we can revise the termination of resuscitation rule for services that have ultrasound and the ability to tell whether or not there's cardiac standstill. So I don't think we're as far away from components of this protocol as we think. It's just the evidence is continuing to emerge that we need to be very aggressive up front. And that requires blood. It requires a couple of other tools. So really interesting.
Well, you're right in that it becomes, well, what is the next step after you deploy it? And that's not answered yet. That's the problem.
I would agree. Yeah, I would agree. You're talking about Reboa?
Yep.
Yeah. What is the next step? Totally agree. But I think we can.
Yeah. No,
Okay.
that's in the ER. So they're thinking of, we do it in the ER, we deploy it to get you to the OR. And that might be it, because that's sort of the longest mile. Once you've made that decision, you're going from the ER to the OR. It's a mess.
Mess is a good word to talk about.
Yes.
Yeah. So back to the theoretical case as we kind of wrap this up. So you had your patient who, and that's the older London helicopter. So you had your patient with multiple gunshot wounds who went into a witness cardiac arrest. So in this theoretical case where you attended this lecture and all of a sudden all of the EMS systems in the world are incentivized, and now you have the ability to deliver all the services. You apply the combat gauze to gunshot wounds, you rapidly insert a supraglottic airway, you don't perform CPR, we do a bilateral finger thoracostomy, they're administering a unit of blood, ultrasound shows no cardiac activity, and we terminate resuscitation. And I don't look at that as a sound outcome. I look at that as a good utilization of resources, because the bottom line is blood is limited, resources are limited, and I think we have the ability to identify the survivors. And by the way, DC has been another jurisdiction that has also deployed blood. And what they have done to answer this question of kind of traumatic cardiac arrest is they authorize, if the arrest has been, or if the arrest occurs, by the way, within 5 minutes or 10 minutes of their arrival, what they're actually doing is they're actually authorizing the administration of blood products. So they'll do 1 or 2 units of blood, even in the setting of cardiac arrest, provided the arrest or the circulatory arrest has occurred within 5 to 10 minutes of arrival, if that makes sense. So kind of interesting. So take-home points for this particular discussion, and I appreciate you sticking with this for the interruption. Is the bottom line is, for patients in peri-arrest, I think we have to get to the point where cardiac compressions are de-emphasized, or at least delivered concurrently, because we also live in this world of Maryland medical protocols while we're addressing all the other life-saving interventions. Those life-saving interventions still have not changed. Hemorrhage control, binding the pelvis, controlling the airway, needle decompression, if you can reliably determine there is or is not a tension pneumothorax, maybe finger thoracostomy, really identifying those survivors, because we've said survivors of cardiac arrest in the pre-hospital setting have also not changed, and essentially targeting those interventions to people that may benefit from that. So I know there's been a lot of discussion about some of the stuff, and what I would like to do is certainly move on to some of the discussion. So we've heard all the literature, we've talked about some of the cases, highlighted some of the resources. Happy to take some questions about this to talk a little bit more about traumatic arrest. So what other questions do we have? So number one is the idea with the ultrasound protocol is to specify when ultrasound can be used in the field. So I would argue that it can do both. So with ultrasound, it is a tool to supplement your judgment. So and this is where we have a lot of people that are either using it or have experience. So this is an open discussion where it's not, certainly not Ben Launer's world. I would argue that ultrasound has a couple of things. Number one, it is a tool to inform your diagnosis. So you can ask very specific questions like we talked about. Number one is there a pneumothorax? Is there lung sliding? Is there fluid? So it can enhance your assessment. Number two, it can be utilized as an assistance, as a tool to inform termination of resuscitation. So for example, if you have a patient who goes into witness cardiac arrest and the decision is, should we work or not work this patient? And let me actually take a step back, unwitnessed arrest. So unwitnessed traumatic arrest with asystole, that patient should not be resuscitated or transported. Unwitnessed arrest, asystole on ultrasound, cardiac standstill, that patient will not benefit from further interventions. So I think you can use it to augment protocols, complement physician judgment or provider judgment, and also use it to terminate resuscitation. I think those are the 2 to 3 main kind of avenues for which ultrasound could be utilized. I don't know if Dr. Swart or Dr. Sagal, you have any other things to add about the ultrasound.
No, I agree.
I love ultrasound. It's the future. I do a lot of cardiac ultrasounds. It's just, I'm always amazed by it. And it answers a lot of questions very quickly. And it's simple.
Yeah. I wish you were integrated more into my lecture, because you say things so much clearer. It is simple. It is the future. Agreed. But just beware, because for me, I have to convince budget stakeholders about what to buy, and I'm mindful of the fact that if you're gonna implement something that does not have a mortality benefit, you have to really discuss how it can do this. And I make the argument in terms of resource allocation and resource saving. So Jeff Henmuth, how are you doing, sir? Speaking of city medics, he asked, what would some of us do with a traumatic arrest and fastest mode of NFP transport? So I would argue that we should not be transporting patients in traumatic arrest. I think if you get them to a helicopter, if the patient is in traumatic arrest, unless there is ROS, I think traumatic arrest does not belong in a helicopter. There are only a couple of situations in which an arrested patient benefits from travel. Number one, witness arrest with immediate CPR in the setting of hypothermia, right? Hypothermia or refractory VFib, where you can maintain perfusion. I think there is not a world in which a patient in sustained trauma arrest benefits from helicopter transport, unless that helicopter operates at light speed, which has not been, despite the AW139 traveling at over 150 knots, unless at light speed teleports people to the trauma center. My personal opinion would be, now it doesn't say don't call them, because you could get ROSC, you could get a patient that is otherwise stabilized, because obviously there's blood vasopressors, they have ventilators. but I would argue that there is no utility for traumatic arrest transport in a helicopter at all. But that's not my world. I don't make those rules. And Jeff, maybe I would argue that there's probably little utility to transporting a patient in trauma arrest anyway. But that was basically back in the earlier discussions of our protocol. So again, that doesn't mean don't call because the utility is low. I mean, maybe it's an issue where you find somebody in traumatic arrest, you know, you decompress the chest or you administer blood or you basically reverse the airway obstruction, then you have ROSC. ROSC is an entirely different story in traumatic arrest, but yeah, very difficult to transport somebody in active arrest. I can tell you my aircraft will not do it, will not transport somebody in traumatic arrest. Now, it's happened, but not intentionally.
I remember on the medicine side of the house, you know, I was always told your survival in asystole after 10 minutes is 0.
Yeah.
And it's the same thing, but they still get transferred. But that wouldn't go in a helicopter either. But even by ambulance, you know, again, now ultrasound for these patients, it's the same thing. They take a quick look and they say, there's no motion, and then they call it.
Now that's another good point. So let's also bring this back to perfusion. So, and Chauncey talked a little bit earlier about end-tidal CO2. Now so we've said where do people that don't survive? And again, the purpose of this lecture is not to be like, everybody dies from traumatic arrest. I think we've said, we know it has a high mortality. What are the patients that can survive? Now, Dr. Sagel, of course, said something very important. Nobody in trauma survives a low flow state that's prolonged over 6 minutes, 6 to 10 minutes. The devastating consequences of traumatic shock are terrible. So if you have somebody that's in prolonged traumatic arrest near your end tidal that's less than 10 and you have no perfusion, that's a patient that's also not doing well. So end tidal can also be used as a negative predictor, unless there's something else that's causing that low end tidal, such as a poorly placed airway or hypothermia. But I think it also is fairly interesting that, you know, we have these patients that get ROSC that are so hypotensive, but if they don't get surgical damage control, if they don't get surgical hemorrhage control within 10 minutes, and there's a low flow state, meaning imperceptible blood pressure for greater than 6 to 10 minutes, those patients don't do very well. So end tidal can certainly be used to kind of prognosticate, right? I don't know if it's ready for termination in the setting of trauma arrest, but it can help you with how well the patient is going to do in the setting of traumatic arrest. Great question. So many of these great questions. What else? A lot of people on here. Well, I'll tell you what, let me just say again that it's been my privilege and pleasure to talk about this. If you want any of the references, happy to share my talk. I can certainly share you any of the references that I have, so you don't have to take my word for anything. I think and thank you for that as well. You're a very engaging audience. The questions are always unexpected and difficult. Dr. Nussbaum warned me that everybody would be very much engaged and ask me difficult questions. The position statements I think are really good, meaning they kind of summarize a lot of this in a very concrete way. And the reality is we operate in EMS systems, right? We operate in systems where we all contribute to the care. We have different levels of providers. And how do we change care on a system level? That's where these protocols and position statements help. So happy to share those with you. And again, I really appreciate your time, and to our guest lecturer, Doug Swart, for stepping in during the unanticipated medical control phone call. Sorry about that.
Thank you so much.
All good.
This was an amazing talk. But it also shows that the future is bright in EMS, and I look forward to it. And
yeah, you know, we always learn. I'm so humbled by all the literature. You know, it's like every time we say something and you have a standard of care, there's always like advancing. So the other option, the other issue to keep in mind is protocols change, right? They change with the evidence. And so you're right, we live in a very dynamic field, and those of us that have the responsibility to care for patients, which is all of us, we really got to read and pay attention to literature so it changes. Yep, definitely.
yeah, if you look in 10-year increments where we were 10 years ago, and 10 years before that, and 10 years, we are exponentially ahead from this, say, even like when this all really started taking off in the late 60s. I mean, we are so far where we were before. It's just amazing, and there's no reason that's not going to continue. Technology being what it is, skill level being what it is, the level of care, what we can do.
Yeah, the technology is fascinating. I mean, I think we've been able to do a lot, right? But I'm also fascinated that, you know, and those of you that this is just basically the after lecture talk and us pontificating, but, you know, I'm struck by the fact that it's not always the technology. I mean, if you were to, I bet you, if you were to have somewhat similar, a similar talk like this delivered in 1900s, I mean, even in World War I, they were talking about giving blood, right? Nancy Caroline's textbook, which in the 1960s, Nancy Caroline, you know, carrying the streets talked about blood. So fundamentally, although we have better technology, like we have better logistics to give blood to everybody, I think there should be no surprise at the most basic kind of tenets of the lecture, right? Don't pour people with fluid, right? And over resuscitate. Give blood if they're losing blood, stop the bleeding, and patients that don't have any blood don't do well. So ironically, things have changed a lot, but in some level, it's kind of bizarre, right? It's the same, meaning some messages are enduring, I think. So
Sometimes
but,
what's old is new.
Doug taught me everything I know. He still regrets it. Harford County leading the way. All right, everybody. Well, if you, Hickman over there asked about ultrasound training. Honestly, there's a lot of links online. Butterfly Academy is also something online. There's a lot of free ultrasound resources. 5-minute EM Sono is one of them. So even just a reputable Google search, and I'm sure you've got a lot of people that can help you with that. There's a lot of good online material. So you can certainly familiarize yourself with ultrasound even without being great resource. Yes, thank you. Focus Geek is a good one too.
Butterfly wants you to buy their butterfly.
They do.
They do. I know a few people who have, and they're actually pretty cool play toys. But
yeah, their academy used to be offline for free, and I think you're right, sir. Now you have to buy it, but the academy is great. They have a lot of 1 to 2 minute videos, but there's a lot of them online. And if you look at any residency program, any emergency medicine residency, there's tons of stuff online that actually shows you the basics. And my only advice would be focus on some very specific indications, you know, like lung sliding and everything else. And I think that will really help you out.
Yeah. Well, for those interested in continuing ed, the link is on the screen. Please fill it out. This lecture will be on YouTube in the future. I think it was amazing. I guarantee you I will be contacting you for next year.
Hopefully you can edit out the thundering silence.
That was actually when you asked for, I put that in there when you asked for questions.
Oh, good.
And then you said something about the Harford County people, and then there was nothing from that. That's when I wrote thunder and silence.
Oh.
Well, I mean, we had a couple of medics on from Harford.
Yeah.
That was before you stepped away. That was the funny part. But it's all good.
I hope I did all right, Ben. I mean,
he did fine.
I don't know. I'll have to listen to the recording, but I do know that somebody's alive and it's going to make it to the MICU here. So, you know.
Are they coming from Aberdeen?
No, sir. They were coming. No. And they didn't call 911 either. They're traveling by air from a remotely located facility that's under resourced.
So not Aberdeen, but similar. It's a free stand in place, man.
No, man. We just had that meeting today. I know.
Well, that was an awesome lecture, Ben. I appreciate it. I didn't know about it until earlier today, and we sent it out, and I figured I'd hop on.
Well, listen, I know we're just we're talking about like a little bit more casually, but you know, we really rely on the topics. I think there's a whole different topic to talk about when even just airway management. So, and I definitely rely on all the people to submit the cases and all the patient encounters. So none of the lectures happen without you guys either. But really good stuff.
Sounds good.
All right, everybody. Take care. Have a wonderful evening. Be safe, and thanks for what you do. Really good stuff.
Bye now.
This is the funnest job in the world.
Thank you very much. Great class.
You inspire me. All right. Talk to you later. Bye-bye.
Thank you.